surgery. So I've just finished my second case for the day. This is a nice patient, comes to me from out of state with what is a history of breast cancer on the right side. So she ended up getting mastectomy on the right, along with a prophylactic left mastectomy. And so she ended up getting reconstruction. Now she has this one set of implants from 2011, so 14-year-old set of implants. So these were supposed to be the nicer, better, safer gummy bear, if you will. So as you will see over here, this is the right side, which I did second actually, simply because you want to always do this cancer side second. This is the right mastectomy scar, and as you will see right here, this is the flap. You can see the upper part of the flap is relatively very thin, so as I touch it, you can see how thin this is. And this is where the alloderm was. And so if I flip this around, you can see the full thickness for what is an aesthetic flat chest closure. This area in the middle, because this was tightened, a nice flat chest closure, this area was redundant, so this was the chest area that was removed for contouring purposes. So for orientation purposes, the stitch is at 12 o'clock. So as you will see on the right side, this is where the entire implant capsule was removed. Some areas relatively very thin. The entire capsulectomy was performed total 100%, and it was a very tedious dissection right off the rib. So as I go in, you will see relatively very thin capsule. You can see my scissors right here, and what is an intact implant. $600 Mentor. As soon as I go in, you'll see what is clearly alloderm. So let me go ahead and show you some fluid around. So if I go like this, you can see that stickiness, it's there. That's the gum sign that I say is like very slippery. And so this is your Mentor M Plus 600 intact implant. Now as you will see clearly, what are these small dots, which is alloderm cadaveric skin from another patient, and so these are the hair follicles, and so this is that robust, allows for robust reconstruction. Even if I try to tear it, let's say if I try to cut through it, it's going to be very hard and thick. As you'll see as I cut through it, it's going to want to not cut, it wants to basically slit, and that's how thick this alloderm is. So that was removed in its entirety. And if you look carefully, there were some surgical clips that are removed. I incorporated those as well. Not uncommon. She had 9 lymph nodes removed on the right side. So as you can see, these were in the proximity of the implants. I'm just going to send this along with the patient so she knows. But overall, all foreign material is removed, including alloderm, surgical clips, which is not uncommon done during the mastectomy time. So there you have it. I'm going to put this here. I'm going to remove my top glove, and now I have a pair of sterile green gloves underneath. So as I go in, this side is the left mastectomy scar, and as you will see right here, this is, you can see how attenuated, thin this flap is. As I flip this around, this is the lateral, this is the medial side, this is the sternal area, and this is the lateral end. The stitch is at 12 o'clock for orientation purposes. This is an outpouching that I removed that was present. Now as I was dissecting, the implant was sitting. This is an area that was super tightly adherent to the rib. So as you can see, this was literally, you can see this is the cartilage part of the rib. You can see the carvings of the cartilage. This is the periosteum. You can see another rib layer here. The fascia of the intercostal muscle. So rib, this was the back end. So as soon as this occurred, I used this plug the sponge to kind of plug this up, and I dissected the rest of it off, and it was just confined. I leave the hardest part, which is the rib, till the very end. So as you can see, it is kind of seals it, so none of it spills into the chest. And if I lift this up, you will see the whole implant is essentially preserved, contained in what was the end block till the very end, and then it became 100% total capsulectomy. And so you can see this is what is indeed a ruptured implant from 2011, just 14-year-old. This is supposed to be the nicer, better, safer gummy bear implant. And so let's see what it looks like. Everything contained, no need for drains. Aesthetic flat chest closure. I'm going to go ahead and move my flap up. And you can see there's nothing gummy about this implant. And it's completely disintegrated. We do not know how long she has been like this, and this is why the dissection in this manner is key, as I described. So none of the silicone is pulled into the chest. And look at the way this is. This is like molten, if you will. If you wait and see, you're going to see this is the shell right here. This is the shell. I'm going to pull it out so you can see. This is made up of a different... You should go online and see how the implants are manufactured. So they make the shell first, and then they basically pour, if you will, the silicone in it. So the shell is different material than this. And you can see, look at this. This is literally crawled out on its own. None of this spilled into the chest. The patient is a very nice, lively patient from out of state, and she did her homework. She was actually very excited about her surgery, and she is exceptionally super nice. And over here, as you can see, look at the way this is rolled up on itself. So what I'm going to do now is, just to be complete, so there is nothing gummy about this. All of this was contained. None of this spilled into the chest. And you can see, look at the way, this is like rolled up like a cigar, if you will. And very interesting. And see how and what the consistency of this is. This is the shell of that implant. And look at this. This is supposed to be the nice, cohesive, it to an extent is, but you can see, look at this liquid type consistency. Look at this right here. So someone asked, why do we need drains? Number one, if any of this spills into the chest, it's going to be very caustic, as you can imagine. It's going to promote some fluid buildup formation. If the capsule is left behind, in my experience, that is toxic burden left behind that will continue to encourage / promote / stimulate fluid formation. If the surgery is done fast, haphazard, and kind of rushing through, it's going to ooze and bleed. If the tissues are not respected in the right planes and the surgery is not done meticulously, now the drains become mandatory. Now if you look at all of my patients, how many of them have come back and say, oh, I need a drain? If you look at none. And if those patients who are not wearing the pressure garments and who are not wearing the bra and the binder, just like after a tummy tuck, the principle 101 when it comes to explant surgery, and then when it comes to any plastic surgery procedure, be it a thigh lift, tummy tuck, arm lift, you will see the patients have to wear A-straps or pressure garments like marina garments, which are specifically tailored to plastic surgery procedures. So you have to wear a pressure garment after any plastic surgery. Tummy tuck, thigh lift, arm lift, just like this, in a similar fashion, where you have that dead space where the implant was sitting, plus the inflammation that was present. Remember, the tissue around the breast is not healthy compared to a tummy tuck where that tissue is healthy. So now there is even more of a reason for 6 weeks after a tummy tuck to wear a garment. It's the same thing over here on the upper chest, to wear a bra and binder. The bra itself holds you nice and comfortably, and the binder kind of gives you a push up so that when you're on a car ride, there is no movement of the chest breast tissue with respect to the chest, so there are no shear forces. So So the drains are not required because the blood loss is less than 5 cc's on each side. There is no residual capsule remaining behind. All that tissue is removed along with the entire implant and capsule, so only good, healthy, viable tissue. Bleeding is minimal. There's complete respect to the dissection and hence the need for no drains. I'm not going to put a drain in because the patient asked me, and conversely, the drains themselves can go in and out, so they can see the bacteria on the outside tubing inward if the tube goes in and out. Normally they secure them with a nylon stitch. And remember, the bulb syringe can open and now the fluid can backtrack, let's say if the patient sleeps on the bulb syringe. So that fluid in itself is not sterile and it can be a catastrophe. Drains themselves can promote fluid formation within the chest simply because you have a foreign material within the chest cavity. So the drains are not required clearly, and to the point where I presented at an international conference and other conferences where the drain requirement is not there for that reason alone. So there you have it. You have to contain all the badness. It cannot spill into the chest. One has to always assume that the implants are ruptured till proven otherwise. As you will see, this nice patient, she got the surgery that we had planned. The alloderm is removed. The entire surgical clips, inflamed tissue, that fatty tissue around has been removed completely, definitively. So the implants will be returned to the patient, capsules to be sent to pathology, rule out the rare BIAL, CL, CD30 analysis. Right and left mastectomy scars to be sent to pathology. And we will see, most importantly, how the patient does post-op minus these toxins. I just want to mention one thing. This nice patient said that she had breast cancer that was like one hit, if you will. The aftermath of having to deal with the implants was much worse, was more pronounced, was more miserable, was more unbearable than the having to go through chemo and having to learn of the breast cancer. This is what she lived with for approximately, many years, and we'll hear from her. She's very eager to talk, and we appreciate her input. So there you have it. This is Dr. Khan, Executive Plastic Surgery.